does we... Thank you. First of all, I would like to thank the organizers for the invitation. It's a real honor to be here. So when does we have a patient with chronic liver disease, the main question is, does the patient has or not portal hypertension? And we must remember that portal hypertension is a clinical syndrome that is characterized by the elevation of the portal pressure gradient, which is the difference between the portal vein and the inferior vena cava pressures. So even if in the Western world the main cause of portal hypertension is liver cirrhosis, we have to remember that other things interfering with the blood flow can cause portal hypertension. We can have a problem with the liver outflow, and we will have post-hepatic portal hypertension. We can have an obstruction in the portal vein or in the splanchnic circulation outside the liver, and this will lead to a pre-hepatic portal hypertension. And when the impairment is within the liver, we still have three classifications: pre-sinusoidal, post-sinusoidal, and sinusoidal portal hypertension. And this is important because when we are speaking about HBPG and the prediction of portal pressure, we are speaking about the specific scenario of cirrhosis, meaning intrahepatic sinusoidal portal hypertension. How do we measure the portal pressure? The gold standard and the most used method is hepatic venous pressure gradient, hepatic vein catheterization. And it's important to remember there is an indirect measurement of the sinusoidal pressure, and it's expressed in a gradient that helps to eliminate the influence of elevated intra-abdominal pressure. In healthy condition, the sinusoidal bed is a low resistance system, and HBPG is lower than 5 millimeters of mercury. So PPG is the interaction between both things, the portal blood flow, but also the vascular resistance that opposes this flow. And this is characterized by the Ohm's law, in which HBPG depends on portal venous system flow, including the collateral flow, and the vascular resistance of the entire portal venous system. Therefore, anything increasing hepatic resistance or portal flow will, or both of them, will increase portal hypertension. So we can do a liver hemodynamic catheterization that can be easily completed with a cardiopulmonary catheterization and a liver biopsy in the same procedure, and we will have a complete evaluation of the patient, the stage of the disease, the presence of hyperdynamic circulation, and also cardiopulmonary complications that may appear with the disease. And how do we measure HBPG? We place a balloon catheter in one of the main hepatic veins, and we measure the free pressure. Therefore, we occlude, after that, we occlude the vein, inflating a catheter, and what happens is that we create a column of blood that will transmit the pressure of the immediately producing territory, which is the hepatic sinusoids. In normal conditions, there is sinusoidal communication that will dissipate this pressure, but when we have liver cirrhosis, there is a disruption in this intrasinusoidal communication, and the wedge pressure will mimic the portal vein pressure. And the difference between the free and the wedge is the value that we give in HBPG. So when is HBPG useful? We know that there is a correlation, a very good correlation with the clinical outcome and cutoffs in the hemodynamic evaluation, and we can use HBPG to diagnose sinusoidal portal hypertension. We can predict decompensation and predict survival in a given patient. So we know from this seminal work from Dr. Grothman in 2005 that a threshold of 10 millimeters of mercury is associated with a probability of developing varices and having a variceal bleeding, and this is what we call clinically significant portal hypertension. And I was just to emphasize that in this trial, no patients with NAFLD were thought to be included, although probably a few was included in this other cryptogenic category. It's also, this 10 millimeters threshold is also useful to predict the development of ascites, hepatic encephalopathy, hepatocellular carcinoma, and also has an impact in the outcome of HCC after surgical resection. We know that over the years, several papers have shown that a threshold of 16 millimeters of mercury is increased with an elevated mortality risk. And although none of these papers included patients with NASH, I can tell you that in the last one coming from the Barcelona unit, a few patients with NASH were included in the other category. It's also helpful to predict outcome and survival in the very specific scenario of the acute variceal bleeding, where an HBPG of 20 or more than 20 predicts the risk of 5-day failure, rebleeding, and mortality, and also in the setting of alcoholic hepatitis, a gradient of more equal 22 can predict mortality. But the good thing is that this complication of portal hypertension can be prevented or reversed by preventing or reversing the HBPG increase, and this is what we call the hemodynamic response. How do we interpret the changes in HBPG during follow-up? We know that lowering HBPG can impact in both the outcome of both compensated and decompensated patients. And lowering HBPG below 12 or having a decrease in HBPG equal to or more than 10%, it's able to prevent the first variceal bleeding episode, prevent ascites, decompensation, and also improves survival. These very recent trials from Spain has shown that the incidence of decompensation in compensated patients after treatment with non-selective beta blockers reduces the risk of decompensation during follow-up, and in this trial a few number of patients with NASH were included. So etiology is changing in more recent trials. Lowering HBPG in decompensated patient, we know since 1995 from the Barcelona group that lowering the gradient 20% or more is associated with decreased probability in rebleeding, and this was also seen in other studies. And not only the probability of bleeding, but also the probability of developing ascites and survival, and has an impact on survival, and this is the aim for the therapy in secondary prophylaxis. Not only with medical treatment, but also decreasing the PPG placing at tips has an impact on survival, and again the threshold of the 12 millimeters of mercury has been associated with a better survival during follow-up. So we can get a lot of information for the HBPG measurement, and it's something that gives us a lot of prognostic information. But if we are measuring HBPG, we have to be very careful, and there are several rules that we have to follow to have an adequate measurement, because it's very important to guarantee the quality of the measurement, to be able to reproduce the data and compare data from one center to another. As Roberto Grossman used to say, anything worth doing should be done right, so please make the measurement of HBPG carefully. But our patients have a NASH etiology, and I have shown you that most of the papers that we have were in others etiology, although the PRODESI study was including patients with NASH. We know that the etiology is changing, and in recent trials, this is only a couple of examples just to show you that in the sport diet trial that was a lifestyle intervention in patients with compensated cirrhosis and obesity. At 25% of the sample had NASH cirrhosis, and also the Enricasam trial assessing the efficacy of a pan-caspase inhibitor in cirrhosis included mostly patients with NASH cirrhosis. And even if those trials, they didn't analyze these patients separately, at least what we can say is that they seem to behave in the same way. However, two concerns have been raised with the NASH etiology. One is that portal hypertension may occur before the development of cirrhosis, and the other one is, and this is because the fibrosis in NAFLD starts in the pericellular space around the central vein, and this has been proposed to cause portal hypertension at earlier stages. And the other one is that HBPG may be lower in patients with NASH when compared to other etiologies. However, the data that we have are very weak. So here I'm showing you 3 different studies. In which the first one is a retrospective collection of 354 NAFLD proben biopsy, and the authors, what they saw is that 12% of the patient with clinically significant portal hypertension, clinical manifestation of portal hypertension, because they didn't measure HBPG, didn't have a fibrosis or cirrhosis in the liver biopsy. The second one is another paper collecting 50 patients with transjugular liver biopsy and HBPG measurement, and again they could see that they had patients with HBPG more than 5 with portal hypertension that didn't have cirrhosis in the liver biopsy, although this paper didn't consider clinically significant portal hypertension, and we don't know how many of those patients had an HBPG over 10 millimeters of mercury. And in the last one, coming from the group in Bern, they evaluated 45 patients, again with transjugular liver biopsy, and this time with HBPG equals or more than 10, and in 4 out of 15 patients, they couldn't find cirrhosis in the liver biopsy despite having clinically significant portal hypertension. But we know that portal hypertension does not always mean cirrhosis, and it has been known since many, many years, and some of us were even not born at that time. And this is why, in fact, it has been shown, because it has been shown that portal pressure determined by the HBPG it's better than liver biopsy in predicting development of complication of cirrhosis in patients with chronic liver disease. In the last Baveno, it was agreed to trying to avoid the term cirrhosis, which is an histological term, and call the disease compensated advanced chronic liver disease, emphasizing that portal hypertension may occur before a formal anatomical diagnosis of cirrhosis is established. So in these papers, the authors conclude that HBPG in NASH patients can be lower than other etiologies, but we have to take into account that they retrospectively collected records of 138 patients that had non-malignant ascites and underwent HBPG measurement, either because they underwent liver biopsy, transjugular liver biopsy, or a TIPS placement. And in global, in general, the group of NASH patients have a lower HBPG when compared to the other etiologies. However, in the same paper, they report that 15 patients developed ascites with an HBPG below 10 millimeters of mercury, and there were no differences in the frequency of this finding in between all the etiologies. And this is the only study that we have in which we have